from the Gym Incorporated. Jim Charlena and myself, Jim Melvina, from the Healthy Lifestyles Committee is presenting a conversation with Dr. Troy Morgan entitled Conversations on Surrounding Glaucoma. But before we introduce Dr. Morgan, let me give you a little information. The Gym Incorporated is an organization that was founded by four friends in Norfolk, Virginia in 1955. We are a nonprofit organization organized exclusively for charitable, educational, civic, and cultural purposes. We have 18 chapters throughout the United States. Dr. Morgan is a native of Virginia Beach, Virginia. He is the son of Michael and Beulah Morgan and the older sibling of Michael, who has always been very influential in his journey. Dr. Morgan is an alumnus of both Virginia Commonwealth University in Richmond, Virginia, and Pennsylvania College of Optometry in Philadelphia, Pennsylvania. While on this journey, he met a beautiful lady who became his wife, LaPortia. They have a smart, talented, and energetic 5-year-old named TJ. For 14 years, Dr. Morgan has owned a private practice in optometry, providing primary care service in Virginia Beach, which focuses on enhancing the client experience in moments that matter. Dr. Morgan is an avid sports fanatic, being a former athlete himself. In his spare time, he enjoys traveling, reading autobiographies, and spending time with family and friends. And now, with no further ado, we'll introduce you to Dr. Troy Morgan.
Hello?
Dr. Morgan? Unmute yourself.
Can you hear me?
Yes, we can. We
Okay.
just can't see you right now.
Okay. I don't know what I need to do with that. And I'm also looking to see, do they have the point presentation? I thought, let's see. I have it, but I don't
Okay, you're coming
know
through.
Let's see. Okay. Let me see. What does she say?
Your
All right.
bandwidth.
Why I can just talk. Oh, it's an unstable.
Hold on 1 second. We're going to see if we
Let
can
me
see
see.
you so we can
I'm sorry.
Dr. Morgan, I can share your PowerPoint for you. You just have to tell me when to go.
Okay.
And
it's all in order. I just can't not can just put out in them. I can just kind of go through the slides, or you can just go through. I'm not sure because I don't.
Okay, give me just
know
a
what to
second.
say. Okay.
Can everyone see it? See the screen?
Yes.
Okay. Thank you. Are you all ready?
Yes, we are.
Okay. Good evening. I just want to say thank you all so much for your time and sharing what we're going to talk about tonight with glaucoma. I hope you find it inspirational, or you can learn something from it. And let's go from there.
Okay.
From what I understand, we're going to talk about with glaucoma. One, what is glaucoma? Glaucoma is basically a series of eye conditions can actually cause blindness. And one of the ways we look at that is from the optic nerve. And that's what the screen, what you see right there, we're looking at like the donut shape. And the larger that donut shape look, can be another sign of glaucoma as far as a risk factor, or the more concerned we can be. Anything over about 50%, like that middle donut hole, if that's anything larger than that, that can be one concern for glaucoma. Next slide. All right, let's see. Yes. And so what happens with glaucoma is you start to get structural damage, and a very slow process. It'll actually start in the peripheral. So you won't even notice it. It will actually go from the side vision, from the all the way out, and it will come closer inward, cause glare and blindness, which isn't good at all, but it's structural damage that actually damages smaller nerves. That's what happens with the structural of, that's what they're talking about with the structural damage of that. Next slide. And so we have a true or false question for you all. Is once glaucoma damages your optic nerve and you lose vision, can vision actually be restored? The answer to that is it cannot be. Well, it cannot be restored. Once you do have damage, so early prevention or early detection is key. And, that's what we have to move from there, as far as making sure you have an eye exam at least once a year or so. If you do have the risk factors that cause that, to get further testing, and that's what I generally speaking as a private practice, independent optometrist, I would refer the client to a glaucoma specialist, because what I would do is just see some of those early indications, and then what I would do is just refer you to a glaucoma specialist, because they can do some further testing to make sure before anything were to increase or damage. And that's what I don't want to happen. Next slide. On the left, what we're talking about, said, what does glaucoma look like? To the left, where you see the child playing stuff, that's what normal vision would be in your quote unquote visual field. To the right, one that's considered abnormal visual field, what happens is it starts to lose vision and it starts to become more blurred. So it seems like the vision is being caved in and it's shrinking. You don't see as much or as clearly as you once would, and which we want to try to control. Next slide. Again, this is just one where it just says normal vision, and then the next, the middle one where it says abnormal visual field. That's where you start to see, if you look to the corner, it's just it's a slow process. And then the one that says abnormal visual field, that can be over a certain amount of time, and it can take years, particularly if it's an angle glaucoma. And start to see that visual field or that blur is starting to get larger. So it went from the lower right corner to the upper right corner. Next slide. True or false? Is glaucoma is hereditary? Yeah, it can be. And what they say, from a higher percentage of stuff, that can be one of the risk factors, and that's one thing that we do take into consideration. So that's one of the things when I'm doing an eye exam. One of the first things I ask is, do you have a family history? And what I mean by a family history, I'm talking about your immediate family. I'm not concerned. Well, not necessarily concerned, but I'm not concerned if it's talking about your cousins. But I'm more so concerned with your parents, brothers and sisters, even grandparents. I like to go down from that chain, because that could be a risk factor, and I take that in consideration with something else, other factors, which we'll talk about later on in the slide presentation. Next slide. These are some of the risk factors that we try to take into consideration as far as with glaucoma. Of course, that can be one. We're talking about 40 plus. Family history, which we just talked about, as far as your parents, grandparents, brothers or sisters, any siblings, ethnicity, minorities, in particular, African Americans, Asian, in particular, trauma. Trauma could be if you got hit in the eye or anything like that, was in a car accident or something like that. Sometimes the nerve can actually be damaged, and it can actually be called closed angle glaucoma that you could actually could die from, actually, because the pressure can build up so much. People start to get nauseous and dizzy, and has been known to even have a stroke, which is can be kind of serious. Steroid use, and what I mean by that is sometimes if for particular, let's say African Americans, if they have lupus or rheumatoid arthritis, and you're on oral steroids, or you've been on those for longer periods of time. Some people are what we call steroid responders. If they've been on steroids for more than 3 weeks or so, that can actually cause the eye pressure to build over time. And you can go from a normal pressure to something be very, very high, which can actually stimulate a cause for glaucoma. Nearsightedness, and when you're over a certain amount, like say a -4 or 5, when you're the more your risk glaucoma they found, and also blood pressure. That is actually one of the newer risk factors that they're still trying to study, because at one time they thought blood pressure was not associated with your ocular eye pressure, but as of newer studies and stuff coming out now, blood pressure can actually be a risk factor. Next slide, please. True or false? Getting the comprehensive dilated eye exam is the only way to catch glaucoma early. True. And the reason being, optometrists or ophthalmologists are some of the first people to see and detect, because you actually looking at the optic nerve. But that's not the only factor. Again, with the family history or different things that may be going on with vision, that is a key component. And then that's when I would refer you to the glaucoma specialist to do further testing, because we just won't look at one eyeball or one on the first visit. So say, yep, that person has glaucoma. But I would say I would consider someone a glaucoma suspect. I would want them to get further testing to make sure to gather up some more information to make sure what else is going on. Next slide, please. And how is glaucoma diagnosed? What we just talked about. One is the visual field, visual acuity. We want to make sure, see how you're initially doing with seeing straight on, even though it starts from the peripheral. It has come in for long periods of time, and it starts to blur. It can actually affect your central vision. By that time, it's very much so in the advanced stages, which isn't good. With the slit lamp exam, that's when we're looking at the front and the back of the eye. As far as the optic nerve is concerned, the tonometer, we're taking the pressures of the eye. Generally speaking, the pressure should be anywhere between 10 and 20, which is considered normal. Anything over 20, that could be an indicator. Although some people who have pressure with between 10 and 20 is called ocular hypertensive. Even that for that individual can be considered a little bit high, and they're going to try to concentrate on lowering that pressure. A gonioscopy, that is where we're looking at the angle. One of the most common glaucoma is what we call open. Open angle is predominantly in African American, associated with the high pressures, and you start to lose the vision from the side over time, a very slow, gradual loss of vision. Closed angle is what we were talking about earlier, where we had trauma, where if the angle is closed, that can actually cause the pressure to become higher, which could damage those nerves faster, and that's where we can actually have a stroke, in which we do not want. Visual field is another test that it detects. Yeah, it's almost I'm not sure if anyone's had this done before, but you sit into a machine and you have a button that you have to press with a light reflex. So anytime you see this light, you're supposed to hit the button. And what this machine will do is this is going to gather information of how much are you seeing from the periphery. So even though everything could be fine, this is another way of early detection of glaucoma where you may not even know it. And then also we have something called an OCT, which is a device that's being used and now where it's basically graphing the different layers and thickness of the optic nerve, which is a lot more than anybody can see what we saw with what we consider with the naked eye. It goes deeper in levels of that, and see over time we can gradually see if there's any subtle changes that we wouldn't even know or see. This is again a lot of stuff that we can consider early detection things, which are very, very important. Next slide, please. Recommendations for eye exams. Now, this is talking, this is what the slide says and different things for people. I always, my standard of care would be that you still need to be seen once a year because I'm all about early detection. And anything that's seen earlier, I prefer that so we can nip it in the bud and get it as soon as possible. Although as the slides are saying, with some of the literature saying under years old, maybe 1 to 2 years, 40 to 54, we're talking about 1 to every 3 years, 55 and older, they're still talking about 1 to 2 years. But again, my standard of care is just once a year, if not no more than every 2 years. But I still say once every year. And we pre-appoint our clients every year just so we can still stay on track with different things. Next slide, please. True or false? The only clinical proven treatment for glaucoma is to lower eye pressure. That will probably say true, but I believe there's other things that can be done. And I think this is one of those ones where technology that we're seeing that's coming about, this will change because there's gradually newer things that are coming about. There's even something I've been reading. So they actually feel that they can detect glaucoma from the back of the eye, way into the back where the brain is. And if they can find a way where they can show and graph is affecting the back of the brain before it gets to the eye, that will be another way to treat even before anyone will be able to notice it, which is some, how could I say it? That would be a life-changing type of different thing for people because then they won't have to go through a lot because they won't even know it in the early detection, just like we do with possibly cancer. Next slide, please. This is a graph of show of just talking about with glaucoma or the pressure in the eye. The best way I try to describe it is inside of your eye, you have a fluid that goes in and out of the eye. And sometimes if there's a chamber that helps to, and I'll show there's another slide with that, but there's a chamber that if it is not allowing the fluid to come in and leaving just as fast, what will happen over time is pressure will start to build. And when that pressure starts to build within the eye, that's where you can start to get this damage of the small nerves and stuff, which can actually cause a loss of vision, which we do not want. And it's called intraocular pressure. Next slide, please. Here's what we're talking about. If you see in the letter A, that's the one that's like if you're washing dishes, and that's when you put that drain in there. Well, you have pressure that's going in and out of that drain. And that when you go to letter B, when you see it start to become a little red, that's where that drain or the nozzle or so washing dishes, that stopper starts to be clogged, and for the fluid that's going inside the eye is not as fast as what is coming in, which water starting to flow too much, and then letter C, and that's where you can see where it starts to overflow, which causes higher pressures, which again causes the damage of the nerves, which can cause visual loss. Next slide, please. How glaucoma. One of the things they can do, and that's on which height you have and what um, how the how doctor wants to treat, but
Dr. Morgan, get closer
additionally
to your
speaking,
mic.
is medications, whether you're on something called, most of the time, as drops that you probably do at night to keep the pressures down, something called light energy that we're going to talk a little bit about. Oh, I'm sorry. Is that better?
I was just saying, get closer to your mic because you're coming in and out.
Hello? Is that better?
Yes,
Oh, okay. Is that better now?
yes.
Okay. Okay. So again, medication is the first, and that's traditional. That's where they put the drops in your eyes, and particularly at nighttime, to try to keep the pressures low, because as soon as when we wake up, generally speaking, the pressure, that's usually when it's the highest. They have another way called light energy, which we will talk about in a little bit, and the other one is an incisional surgery that they will do. Next slide, please. These are some of the most common medications that are being used right now. And some of the newer stuff that's coming out now, they have an oral pill, which is great for some people who just can't do drops. Or when you try to use the drops, they go all anywhere but in the eye. I know I struggle with that. There's also, they have a pellet that they think they can do to put in the eye and release on the eye, so it gets you the proper dosage, versus with the drops, where sometimes we miss or we don't get the right amount, or the people aren't shaking the medicine up first before they use it. So this will make sure you get the consistency and the compliance and the right dosage. Next slide, please. This is the second one, called the light energy. And these are, I guess you can say, kind of minor surgeries or invasive. It's not really that bad, but what they do, like, remember, I'm not sure if you all recall with that sink that I was talking about with that stopper, but basically what these surgeries would do is they would go in and they would actually create small miniature holes in that stopper to create more holes for the fluid to continue to go in and out.
Mhm.
Kind of like putting a like Swiss cheese, or adding holes in there, or in the dam. You're just making little small incisions in order for fluid to pass through, come and go.
Mhm.
Next slide, please. And then we have the actual surgeries where they can go in and they do different things, like that's a lot more invasive, which they don't tend to do, especially at the beginning. They prefer to do the other two first, but these are some of the things that they want to do once it's the other two methods did not work, or not as successful as they would like. Next slide, please. And again, these are some of the other procedures they call stents, or different things like that, where they, again, trying to unclog the drain, or flush the drain. Next slide. And these are some other ones that, again, can be very invasive, and they're calling about what the stents and stuff, where they're just trying to transfer fluid and stuff as much as possible. Next slide. Yeah. And these are some of the tips that we recommend. First, don't ignore signs. If you think something's wrong, definitely go in to get checked out. Sometimes you have to cover one eye or so to see if there's one that's seems like it's not as clear as the other. Uh, accept the disease and don't accept defeat, because there's technology is always changing and always advancing. So what we're talking about today may consider ancient by this time next year. We just never know, because technology is always advancing. Um, don't be afraid. Don't be afraid to ask questions to your optometrist or your ophthalmologist. They're there to help. Definitely take glaucoma seriously. Partner with your doctor, and that can help by just make sure you're seeing them on a regular basis. Ask questions about, know what to expect if there's any procedures that need to be done. Keep your medical records. That always helps, particularly if you have to switch doctors for whatever reason, or if you have to transfer to another doctor, because sometimes they may not get the notes as fast as what you could have. Talk to your family members and friends. Let them be aware of that, because sometimes you may need a buddy or someone to go with you, or they may have a question to help you as well that you may not think of, especially being a little nervous. Um, of course, always be honest with yourself about your situation is not as bad as what you think. Um, know the risk associated with glaucoma, and then ophthalmologists or the optometrists will manage it, and it's a great partnership. Next slide. So here's the key takeaways from this lecture or so, the presentation. What does glaucoma look like? Again, it can start to blur not the central vision, but it will slowly blur the peripheral vision, where it can get to the central vision, what we do not want, which will be total blindness. Why, who's affected by glaucoma? Anyone can be, but of course the risk factors as far as your age is concerned, ethnicity, if you're on prolonged steroids, some of those different factors. We've talked about how it's been diagnosed. Make sure you're seeing your doctor. The different techniques they're going to use to gather all the information to see if you do have glaucoma. We talked about some of the different occasions or the surgeries or the minor procedures where they open up that to make sure that fluid is going in and out. And we talked about some of the things you can try to help to prevent blindness and stuff. So that's what I have there. And I guess I will take any questions or anything that I can do or try to help.
Does anyone have a question for Dr. Morgan?
You're muted.
I'm muted?
No, Charlene.
Oh.
That was Melvin. Does anyone have a question for Dr. Morgan?
Yeah, Charlene had her hand raised. She was
Okay.
muted.
Okay.
Yes.
Oh.
Thank you, Dr. Morgan. That was a very thorough presentation based on what I know. I've been recently diagnosed with glaucoma.
Okay. Okay.
And have been referred to a specialist. And
yes.
my optometrist has stated that it will be an incisional procedure.
Okay.
My right eye is the one that has been impacted. I've not seen any significant change in my eyesight. Is that normal? I do experience more tiredness. I think that's probably what it is. But what he did, he increased the eye drops and gave me a new eye drop. I've been on three for the past several years. And at one time, the pressure in both eyes. As a matter of fact, as late as a couple of years ago, they were about 12 in each eye.
Okay, that's very good.
Yeah, very good. And
Very good, absolutely.
But recently, it has increased, and my right eye is now reading in the 20s, low to mid 20s, and he has indicated that there is nothing else he can do. I've been on all kinds of eye drops, and has referred me to the specialist. What I want to know is, and I know it can't be reversed. I know that I've accepted that. Is there anything that I would like to know if there's anything that I'm currently doing that might make it worse? I'm on the computer a lot. I have eye strain. And so, and I was wondering if that, I failed to ask him that. Is eye strain making it worse, or how?
No, ma'am.
Okay, great. Glad to hear that.
No, ma'am.
Okay.
No, ma'am. There's nothing that you have done or nothing that you have caused. This is more so a fluid that we know of at this particular point. But you have a fluid. It's almost as if you're producing a lot of fluid and it's not leaving the eye as fast as you're creating it. Right. Basically, what's happening, and what that study was trying to do was trying to open up the channels to try to compensate for that, particularly the fact that you've done that for so long and it was so consistent. And what he's seeing now is in the pressures are in the 20s or so. So what he's wanting to do is send to the specialist to see if there's any other procedure that they have to go to, that one where they provide a stent or something, just to knock that pressure down, to again to stabilize that vision and make sure you don't lose any other vision.
Okay. Well,
but there's nothing that you did wrong. Nothing that you did wrong. Not at all.
Okay. Yeah, I'm concerned. I said, what is there anything that I need to stop doing? So I was just wondering.
That's the $1 million question, but I don't think so at this particular time. But again, I am so optimistic about what's happening with glaucoma and what's getting ready to occur. I think a lot of things is like with red tape and stuff, very high with technology, what's going on now, because again, what we're talking about now may be considered ancient, let's say in the next year.
Mm-hmm. Okay.
We just don't know.
Okay. Did I contribute to the pressure by a lifestyle or something? How did that happen? Based on the fact that they both were in the 12s and 13s, and I'm not going to hog this session, by the way, but is there anything that caused that pressure to rise like that significantly
right
over that period of time? Okay, and let me give you another risk factor. I have 4 out of the 6 risk factors.
Okay.
My mother had glaucoma, for one, you know.
Okay.
But I have 4 out of the 6 that you named, that you showed.
Okay.
Mm-hmm.
Okay. At this point, it sounds like it's more so of a genetic thing. The only thing where you could have possibly caused high pressure so would have been if you were on long-term steroids like Prete or prednisone, or if you had some type of trauma. But other than that, more is a genetic component, at least that we know of as of now.
Mm-hmm. Okay. Yeah, well, that's what I was saying. One other question, I'm going to end this. How accurate are the visual fields? Are they very accurate? Because sometimes I see the dots and sometimes I don't.
Okay. What do you
But
mean by that?
oh,
We're talking about the results?
I'm the visual
What do you
fields.
mean? Okay.
Are they very accurate?
They can be, but that's where you have to take several ones because sometimes you can have an off day or you weren't looking or understood what was happening. And that's where they will look at things and they look at it consistently. So if you've been consistent and they say, well, this just doesn't seem right. It could have been you were pressing the button before or you did not quite understand. I've seen where they didn't even patch the other eye and the person didn't know. But they can be, but they do it over a series to look to see where's the consistency or where it could be inconsistent. So it takes more than I would say at least 3 to 6 of them, and then they gathered all of them together and see what has been happening or what's the medical treatment. Has that been working or it has not been working?
Okay.
But that's just one component. They're going to add that with the other testing and stuff to see, not just one test.
Right. Okay, because sometimes I'm not sure about the visual fields and how accurate. Okay. Well, I guess that's it. He did tell me that I need to watch my pressure, my high blood pressure as well.
Yes, that's something new. It's because at one time they didn't think high blood pressure had anything to do with their ocular pressure.
Right.
At one time, they think that.
Okay. Well, thank you so very much. I got quite a bit from your presentation, and of course, I'm
glad you. Thank
quite
you. Great
interested
question.
because of my situation.
Absolutely, absolutely, absolutely. But I'm going to learn some more from your specialist when you go see the specialist. I would bring those questions too.
Right.
I would.
Right. So there's nothing I can do at this point other than go and have my surgery, I guess, when it's scheduled.
I would, unless the specialist sees something different.
Right, which I'm hoping. Okay, thank you so
Right.
much.
No problem.
Does anyone else have a question for Dr. Morgan?
So I'm the only one going blind, huh?
No, you're not. I was concerned about when you said the blood pressure. That's something
Right.
I would have thought that that was something that they would have looked at anyway, but particularly because so many of African Americans have high blood pressure, I would think that it would have, it has effects on the heart. So therefore, why not some of the other organs or things?
Absolutely. Absolutely.
You did say ethnicity is
a factor.
one of the risk factors there.
Yes. African Americans, Asian descent. So yes. In particular, yes. Higher risk.
Yeah. Okay. I have that. My eyes, am I more prone now to have dry eyes?
Yes.
Since I've been diagnosed, this diagnosis is very recent, by the way.
Right. Sometimes with the drops and stuff like that, they can cause a little bit of irritation with the eyes. More so with the drops. But now one of the side effects of some of them, though, they make your eyelashes grow. But yes, you can be more prone to dryness. Yes.
Yeah. I'm not necessarily interested in eyelashes growing. Not necessarily.
Right. That's one of the side effects, though. Yes.
Okay.
Yes,
well,
ma'am.
I don't know. I'll take it. I'll take it.
I heard that.
Anything to make me look better, I'll take it. If that's gonna help me. Okay.
All right. But thank you, Jim Charlene, for your questions. And I'm pretty sure that since you have been recently diagnosed, some of the questions that you asked and that he covered for us, many of us, because we haven't experienced those things
Right.
yet. And
Okay.
so therefore, we're not as up on it. And we were listening to the presentation so that we could learn a little more.
Mhm.
Thank you very much for your
One
request.
other thing, Dr. Morgan, since I've been diagnosed, I'm trying to I'm thinking about trying to delay any surgery. I'm sorry. For a few weeks.
Okay.
Am I in the danger zone by trying to do that?
No, ma'am. No, ma'am.
Okay.
No, ma'am. No, ma'am.
And I think most of
Or
my
even if you want to get a second opinion. No, ma'am. You're
well,
not.
you,
No. Or
yeah,
like I say,
no.
even if you want an opinion.
I think most of my members here know why I'm trying to delay it, but
Okay.
but anyway, thank you for that. That helps me too.
No problem.
Mhm.
No
I have a
problem.
question.
Yes.
It's not about glaucoma. What causes dry eye?
What causes dry eyes? There's several things that can cause dry eye. One, allergy medications, blood pressure medications, fans, or when you have your air conditioner on high, or if you have your heat on high, that actually takes out the natural moisture in the eye. Um, let's see what else can cause dry eyes. Those are some of the main ones right there. Also, when you're we don't blink as much, and also as we get older, we don't retain fluid and stuff as much, and that can cause a little bit of dryness. And what will happen is your body recognizes that your eyes are so dry that it will overproduce tears to compensate for that, and that's what will actually cause you to tear. Because I know a lot of people say, "Why, if my eyes are so dry, why are they tearing all the time?" And that's some of the things. There's different ways to try to help with that. I always start bare minimum artificial tears, sustain or refresh. I encourage clients to make sure that they eat proper nutrition as far as like your fatty tissue. I mean, fatty fish, like your salmon. Um, Also, sleep with a humidifier sometimes, or just don't have a ceiling fan on. But one of the main ones, at least here in Virginia, because we have allergy, that's almost like a year-round thing, is allergy medication. Because allergy medications don't just go to one particular place; they dry out any and everything, as far as your eyes, your mouth, your underarms, under your knees or something, like anywhere where there's moisture in your body. That's where it goes and it attacks to dry out. But when it does that, it can particularly go to the eyes.
So, what medication over the counter do you recommend?
Artificial tears like Sustain or Refresh. You can use those 4 to 6 times a day. You can't overdose on that.
Thank you.
Thank you, Kay, for those questions. Anyone else have a question?
Is diabetes, excellent presentation, Dr. Morgan. Is diabetes a factor with glaucoma?
Yes,
or can it be?
that is one of the newer ones they're trying to say now. Yes, ma'am.
Okay. 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 Thank you.
No problem.
Okay. Janet, thank you for that question. Thank you for being on tonight.
Okay, you're welcome. I enjoyed the presentation, Melvin.
Thank you.
Yes, indeed.
Thank you.
All right. If there are no other questions, Dr. Morgan, I wholeheartedly appreciate you doing this. And I know it took a lot, and it took your time, and I'm so glad you were able to come on and share this information with us. And you have helped us understand glaucoma a little better and some of the other things that we
Okay,
can do.
great.
Yep. So on
Thank you
behalf
so
of,
much.
okay, on behalf
Thank
of the
you
Jim
all for listening
Incorporated,
and stuff.
we'd like to thank you. And Jim, Charlena, do you want to say anything? My chair, my other chair.
I would like to thank you very much for giving us some information and then the visual to help us better understand what it is about our vision. And I was taking notes. I'm a health and PE teacher, so I was taking notes. So I'll be using this for instruction for middle school students. So thank you very much.
Okay.
Okay.
No problem. Thank you all so much for your time.
All right.
Thank you.
Dr. Morgan, I'm sorry.
Glad I was able to help. Thank you.
Okay, we weren't able to see you, but we got the presentation. So, and of course,
Yeah, I'm sorry about that. That probably did y'all a favor. That probably did a favor.
That's all right. That's quite
Dr.
all right.
Morgan, I thought it was my eyesight why I couldn't see you, but I just
That's what I heard that. I heard that. It was a conspiracy to get you in there to see.
I was wondering if I was the only one who couldn't see.
Okay, they have jokes. All right. Well, thank you
Okay,
very
thanks
much.
everybody. Good to see everybody.
And thank you all
Excellent.
for being on tonight.
Excellent.
Thank
Excellent.
you.
No
Good night,
problem.
Dr. Morgan.
Thank you
Okay, bye-bye.
so much. Take care. Have a great weekend. Good
All
night.
right, you
Thank
too.
you. You too.
Good night.